Good afternoon. My name is Phillip Newsome, and thank you very much for the invitation to speak at the meeting today. I'm going to speak today on new therapies for NAFLD and hope for the future. So currently available treatments are indicated in the slide here. As you can see, there are no licensed therapies approved. Weight loss is the mainstay of therapy at the moment, really looking at a combination of lifestyle, weight loss medications, and on occasion bariatric surgery. But we know that it's difficult for our patients to lose and sustain that weight loss. We also know that patients with NAFLD have increased metabolic comorbidities and mortality, and therefore it's important that we optimize their glycemic control, hypertension, and also dyslipidemia. Now, there are two treatments which are recommended by EASL, ASLD, and other associations, vitamin E and pioglitazone, but they've not been through the full evaluation, and therefore they're not licensed therapies. As you can see on this slide here, there's a huge amount of activity ongoing at the moment, large amounts of investment coming in, and this really targets all elements that might be relevant in NAFLD, whether it's upstream in terms of weight loss, insulin sensitivity, metabolic elements, whether it's, as indicated in the top right, therapies focused on inflammation, or whether it's for therapies that are focusing on liver fibrosis. And in some occasions, you have drugs targeting multiple pathways. Now, there aren't any currently licensed treatments, but as you can see from the right, there's a huge amount of activity. So hopefully, we will have treatment soon. So the good news is that both the European and American authorities have agreed a pathway for approval of drugs. I guess the challenge is that if you look on the right, the hard clinical endpoints, which will give you full approval, are fairly, it's a high bar, so mortality, progression to cirrhosis or transplantation, or a MELD score going above 15, or liver decompensation events. So if you meet those targets in a clinical trial, your drug is fully approved. On the left, what you see are provisional approval endpoints, which are predominantly histological endpoints. So if a drug achieves resolution of NASH on histology or improvement in liver fibrosis, it may be given provisional approval, which means the company can use that, can market that agent, so long as the trials continue to meet those hard endpoints on the right. So I'm going to talk through some of the particular agents here. So FXR agonists such as obeticholic acid, a range of potential actions, whether it be insulin sensitivity, whether it be inflammation, or what I think might be the more relevant one here is a reduction in stellate cell activation, so shifting the balance towards a reduction in liver fibrosis. So this agent is the first one that's been through or is halfway through phase 3. It met its, the interim analysis was presented, which I'll come on to in a second, recently. So you see it's a very large trial, so just under 2,500 patients. The end of the trial is determined by the number of hard clinical endpoints, so that's difficult to define. And the interim histological endpoints, in keeping with the previous slide from the EMA and the FDA, are those histological endpoints there. And this really followed on from the phase 2 trial, the Flint study, which was published a couple of years ago, which showed improvements in phase 2. You'll notice there's two different dose arms being tested. So these data were presented by Zerbe Yonossi and published at the ILC 2 years ago and published in the Lancet in 2019. So these are the two either-or endpoints, and you can see it met fibrosis improvement by greater than one stage. So just under a quarter of patients receiving the highest dose achieved that, and that was significant compared to placebo. Interestingly, there wasn't a difference in resolution of NASH. So on this basis, the trial continues forward to the hard licensing endpoints. One of the things that's worth noting in the adverse events is that there is an increase in itch. You can see there that's dose dependent. And I think what we need to understand is what the effect of that will be on patient adherence. There's no doubt that if patients have got advanced disease, they're more likely to continue with treatments. But it is a consideration when we're considering a condition for which, in the main, there are no overt liver symptoms. The other point to flag is the alteration in the lipid profile. The red arrows indicating the deleterious changes that are seen with obeticholic acid. So theoretically, this might result in an increase in vascular outcomes. We'll see if that's the case. Of course, many of these patients, as they develop aberrant lipid profiles, will often switch to statins, which perversely may end up in a more significantly advantageous lipid profile. So ultimately, we just need to see what happens. Other agents which are worth elaborating on, as I said, there's a huge amount of interest here, is FGF19. So this is the engineered version, aldafermin, and many different phases of investigation with this agent. But what you can see, and these data were presented by Steve Harrison a year or so ago, is you're seeing histological improvements here in terms of fibrosis improvement in about 40%, and resolution of NASH in about a quarter of patients. So there's a pleiotropy of actions with FGF19, and I think it looks like a promising agent as we move forward. Lanifibranor, again, recently presented at the American Liver Meeting and coming out in the New England Journal soon. So lanifibranor, as you can see, is a pan-PPAR agonist, as opposed to drugs like elafibranor, which had an action on PPAR alpha and delta. So you see that effect there, potent effect on alpha, delta, and gamma. And the good news is that this builds on substantial healthy volunteer data and data in patients with type 2 diabetes. So this is the study here. It's a relatively short study, the phase 2 trial, 6-month study with 2 different dosages of lanifibranor. And again, histological evaluation up to 6 months. So these data were presented, and I'm going to present, these aren't the primary endpoints were met, but I'll present the secondary endpoints because they align more closely with the regulatory standard. And what you can see here is, potent effect of lanifibranor on NASH resolution. So just under half the patients achieved that. But interestingly, if you look at fibrosis improvement, there was, a significant effect there again. So 42% of patients achieved that. And of note, just under a third of patients had both an improvement in fibrosis and also resolution of NASH. So really interesting. You see this effect was consistent in both patients with diabetes and those without. So that's proceeding now to a phase 3 clinical trial. So really exciting as we move forward. So now I want to come on to Glp-1 analogs. These drugs are in widespread usage for the management of type 2 diabetes, also in common usage for patients with excess weight. Now, I think the thing to say about these drugs is that when it comes to weight loss, this is principally driven through its effect centrally on the hypothalamus, and we know it successfully suppresses appetite quite significantly. It also has an effect on gastric emptying, which may contribute to that. The effects on the left on the pancreas are clearly responsible for its effects and its indication in diabetes. But what's interesting is that there is a suggestion that there may be an additional weight-independent effect through effects on inflammation. And there are some studies suggesting a potential direct liver effect, although I suspect the major action here will be delivered by its effect on weight loss. So the SEMA-NASH trial, as indicated here, that followed on from previous study with liraglutide, which we performed in patients with biopsy-proven NASH, and that was published in The Lancet. This study here is a conventional phase 2b trial with semaglutide, a sort of successor drug to liraglutide. This drug is more potent. It's a modified version of liraglutide, and it gives you a more prolonged action. So again, as I said, its focus in this particular trial is on patients with biopsy-proven NASH. The endpoint is, as indicated on the bottom, resolution of NASH, with no worsening in liver fibrosis. A confirmatory secondary endpoint was that other endpoint of improvement in liver fibrosis. So you can see 3 different dose arms. The duration of trial was 1.5 years, allowing for at least 24 weeks for up titration of the highest doses of semaglutide. So this is the primary endpoint, looking at resolution of NASH with no worsening in fibrosis, and this was studied in patients that had stage 2 or stage 3 fibrosis. And what you can see is that this was a significant achievement in that just under 60% of patients on the highest dose of semaglutide met that endpoint. Now, the way the study was analyzed was the statistical analysis was focused on this highest dose of NASH resolution, and then it looked at fibrosis, and then it continued in that way, next dose of semaglutide and NASH resolution, and then fibrosis, and so on. So it was significant for this, but because, as you can see in this next slide here, it wasn't significant on fibrosis. There were no further analyses. So the take-home message is significant, clearly very much so in terms of NASH resolution, but in terms of its effect on fibrosis, that wasn't significant. But as you can see on the previous slide, you're seeing good effects on NASH resolution at the other doses as well. So in this study, we went on to look at changes in fibrosis stage, which was a pre-specified secondary endpoint. So what this slide indicates really is if you look at burgundy, that's patients sorry, in orange, I beg your pardon, that had worsening of liver fibrosis. So the key point here is that in the placebo group, we can see that about 19% of patients had worsening of fibrosis over that period of 72 weeks. Whereas if you look at the different doses of semaglutide, that number gets smaller and smaller. So, only 5% of patients on the highest dose of semaglutide have worsening compared to those on placebo, and that was statistically significant. If you then look at the next slide, this looks at some of the non-invasive markers of liver fibrosis, so the enhanced liver fibrosis panel, and also liver stiffness as judged under transient elastography. So what you see here is a very similar picture, namely that there is a dose-dependent improvement in these parameters as you increase the dose of semaglutide. So you can see here that whereas with the placebo, there's a slight increase in ELF, in the semaglutide arms, there's a reduction in those. And similarly with transient elastography, there's a reduction with semaglutide, but no effect with a placebo arm. And these data, as you probably saw, were published in the New England Journal towards the end of last year. So on this basis, it's important also to think about cardiovascular effects. We know, for example, that patients receiving GLP-1 analogs for the diabetes indications have also supported by data from cardiovascular risk studies, which are important from a regulatory perspective. So what you can see here is for a range of different GLP-1 analogs, that by and large there's a reduction in major adverse cardiovascular events. And if you look in particular with semaglutide, the SUSTAIN-6 trial, what you can see, these started up as non-inferiority studies. You can see clearly it's certainly not inferior to placebo, but in fact it's also superior. So the good news is that with this class of drugs, GLP-1 analogs, you seem to get the predictable beneficial effects on weight loss and glycemic control, but also you're seeing reassuring data on cardiovascular outcomes, and also seeing significant improvements in NASH resolution. So I've touched on hopefully some of the potential therapeutic agents which will be coming out in the near future. I think one of the challenges is knowing, are we going to be using monotherapies? Are we going to be using combination therapies? And this slide really tries to capture some of the potential combinations that may come through in due course. These are trials which are ongoing. And as you can see on the right, these are sort of reasonable sized studies in the region of 100 to 300 patients. And what they've tried to do is combine, in many cases, complementary mechanisms. So what you have here, for example, is the combination of a GLP-1 agonist with an ACC inhibitor with an FXR agonist. We have other ones which combine anti-inflammatories, potentially with CCR2, CCR5 with an FXR. Others are combining FXR with SGLT1 or SGLT2 inhibitors. And here you're seeing other ways of looking at that. So I'm sure that as we go forward, we're going to see more data emerging with the combination therapies. And I guess what this indicates here on the bottom is how you might intuitively combine them. I think one of the things that we don't really know when it comes to liver fibrosis in this group is that, thus far we've seen agents which potentially have a more potent effect on NASH resolution, but less so on fibrosis. But we don't really know when it comes to targeting fibrosis, how long it will take for effects to become apparent. If, for example, you have a therapy which is a directly acting antifibrotic, you might logically expect to see a nearer term effect. But for drugs that have an effect on the indirect effects, in other words, drugs which reduce inflammation or weight, we just don't know how long that will take before it starts to have an effect on liver fibrosis. We know, for example, with hepatitis B that it often took up to 5 years before you saw, resolution of cirrhosis with the highly active antivirals there. So I suspect, we need more data to tell us over what time period we can realistically see an effect. So now what I'd like to talk about in my final slide really is, the paradigms of treatment. One of the questions is, well, which patients, are we going to be treating with these drugs when they're approved? Well, I think there've been a reasonable number of data sets now which tell us that the greatest risk of a liver death sits with patients who have F3 fibrosis and cirrhosis. And I think given the time scale of progression from F2 to F3, which is often 7 to 10 years, if not more, I suspect that treatments are going to be focused, on our patients that have F3 and F4 disease. Now, of course, F4 is a higher unmet need, but by the same token, it's also a condition or a severity for which we have even less data that support the effective use of agents. So whilst it's a greater unmet need, it's also a more challenging situation to have therapies. So therapies will obviously there come a little bit later and be reserved for agents which have demonstrated that efficacy. I think the other paradigm that we need to get our heads around is that probably treatment for these conditions will probably be longer term. I think hypertension is a better paradigm here. I don't think it's going to be a Hep C paradigm where you treat for a defined course and then you're done. I think it's going to be a longer term therapy. I think that the mainstay has to be not just behavioral change, but I think we need to think here about environmental change. I think, when you look at the burden of obesity in many countries, it's naive to think that telling somebody to lose weight is going to be sufficient. So I think we need to make those regulatory changes in terms of the environment. We also need to enroll patients in weight loss strategies that are sustainable. But undeniably, that's not going to work. And there will be a substantial number of patients, and depending on the data you look at, that's probably up to about 1% in most populations will have bridging fibrosis. So I think for these individuals, I think the mainstay will probably be an agent that achieves weight loss, along as sensitizing insulin in those patients. And I think that's because with that, you'll get not just the effects on reducing injury, but you're going to get the additional effects. We know that when it comes to cost effectiveness of therapies, if you have a therapy which improves weight and insulin sensitivity when it's being used for NASH, you're going to start to accumulate additional benefits. I think having said that, we're probably going to end up in situations where we've tried, for example, an SGLT2 or a GLP-1. For patients where it works, that's great. But for other patients where you're getting an effect, but not enough of an effect, I suspect at that point, we're going to add in other agents that target discrete pathways. And that might be even more relevant for patients with cirrhosis, where even in the trials, we recognize that one agent isn't enough, and we need to combine that treatment with another if we're going to see an effect in the sort of realistic time frame. Now, that could be, those combinations could start as a combination. It might be start off with one and we add on, and I don't think we really know the answer to that. As I said, I think many of these treatments are going to be lifelong. I think the caveat here is that for patients with cirrhosis, I think the treatment will be pulsed. And that way it will allow for a short duration of treatment to achieve an effect, and then we can hold off with an antifibrotic whilst continuing with the antimetabolic therapy. So I've hopefully illustrated my thoughts on how the field will evolve. I think really exciting at the moment, really exciting for patients, as finally we have treatments that are coming up in the near term. So thank you very much for your attention. I hope you have an excellent meeting and look forward to hopefully meeting you in a face-to-face meeting in due course. Thank you very much.